Okay, in this video we will be discussing about idiopathic pulmonary fibrosis IPF. IPF is also known as unusual interstitial pneumonia. Most of the authors use this term UIP, usual interstitial pneumonia. But remember, this is a pathological term, not a clinical or a radiological term, but a pathological term, right? So UIP or IPF, we do not have to confuse the two terms because these two are the same thing. One is the clinical or radiological finding and second is the pathological term. So the most common type of ILD is IPF, most common type, but at the same time it carries a very poor prognosis, or you can say the worst prognosis of all kinds of ILDs. Age of presentation is 50 to 70 years and it is more common in males. It is associated with smoking. Most of the patients are smokers. 3/4 of the patients are smokers, right? Prognosis is very poor. Median survival is 3.8 years. That's it. Because most of the times the drugs, the medications that we give, they are not effective at all. Steroids are not effective in this disease, and the disease relentlessly progresses, and eventually mortality occurs, and the median survival is 3.8 years. Right. What will you see on histopathological examination? As far as clinical features are concerned, right? Let us not talk about HPE at the present. Clinical features will be, will be non-specific, or you can say it will be like all other ILDs. The most common symptom will be dyspnea, which is basically exertional dyspnea. And the other most common symptom is dry, non-productive, chronic cough, right? And a very important sign is clubbing. It is not seen in all the cases, but it can be seen in a few cases. On histopathological examination, the hallmark of idiopathic pulmonary fibrosis is fibroblastic foci. You will see that there are foci of fibroblasts which intervene the normal lung interstitium or lung parenchyma. There will be fibroblastic foci in between, right? So on biopsy or on HPE, we will also find honeycombing. There will be little or no inflammatory cell infiltration. So basically there is no inflammation, and if there is no inflammation, there is no role of steroids. Steroids do not work in this situation. It is seen in posterior basal parts of the lungs. Remember, most of the idiopathic lung diseases or idiopathic pulmonary fibrosis or lung fibrosis, the lesions, the area involved is posterior basal parts of the lungs, posterior and basal. As far as HRCT is concerned, which is the gold standard investigation for ILD, predominantly affected region is posterior basal lung fields, right? There will be reticular opacities and there will be honeycombing. Honeycombing implies severe fibrosis. The severe fibrosis distorts the architecture to such an extent that there will be traction bronchiectasis, right? So 3-4 things we have to remember: posterior basal lung fields, reticular opacities, honeycombing, and traction bronchiectasis. What is the treatment of this condition? The only treatment that we can give is pirfenidone and nintedanib. But remember, there is no mortality benefit with these drugs. They can delay fibrosis to some extent, but mortality eventually occurs. The decompensation is fast. It will occur in 3 to 5 years. Median is 3.8 years. So basically no drug is effective. The only drug which are effective to some extent, to very little extent, is these antifibrotic agents, that is pirfenidone and nintedanib. right? uh, this is the HRCT image of ILD, in which there is, you know, there is honeycombing all around. You can say, you can see here there is, a patent bronchi, you can see, but you see that this is kind of very much widened in bore. This is because of traction, the traction caused by the fibrosis. So this is a very severe case that we are seeing over here, right? It is a very severe case, right? Because it is a severe case, so we are seeing mostly the zones involved are the posterior and basal, but in this case you can see the whole of the lung field is involved. There are ground glass opacities, there is honeycombing in lower zones as well as in upper zones, right? So this is a severe case. Mostly you will see in starting of the disease the involvement is in the posterior and basal parts only, right? So this is honeycombing. And you can also see traction bronchiectasis in this case. To revise, there is idiopathic pulmonary fibrosis, also called as usual interstitial pneumonia, which is a pathological term. Clinical features are dyspnea, dry non-productive cough, chronic cough, and clubbing. Most common type of ILD, worst prognosis, median survival 3.8 years, fibroblastic foci, honeycombing, inflammatory cell infiltration on HPE, on HRCT, which is gold standard. Predominantly affected region is posterior basal lung fields, reticular opacities, honeycombing, traction bronchiectasis. Treatment is basically antifibrotic agents, pirfenidone, nintedanib. There is no mortality benefit, but they can slow down the process of fibrosis to some extent. You can see an image over here just to revise. That's all about IPF. Thank you.